So for the objectives, we're gonna just go over the basics of ultrasound-guided nerve blocks, indications, contraindications, complications, and then we'll talk about two blocks that are good for hip fractures, as well as some of the evidence behind them. All right, so indications for an ultrasound-guided nerve block or nerve blocks in general, large areas that require analgesia, like large burns or lacerations. You maybe don't want to inject a lot of local anesthesia in a large lac. It may cause it to be distorted and a lot of edema and a lot of pokes as well. So a nerve block would be good in that instance, as well as the opportunity to use less opioids for pain, especially in older patients, and avoiding sedation when possible. Contraindications to performing a nerve block would be any concern for overlying infection, allergy to the medication that you're going to inject, any injuries that are at risk of compartment syndrome, and then if the patient is unable to cooperate with you. So if patients who are altered and you can't get a good neurovascular exam, you shouldn't perform a nerve block on those patients because you need to document a good neurovascular exam before you do any nerve block. And relative contraindications would be patients who are anticoagulated or who have coagulopathies. Okay, complications of nerve blocks. So anytime you put a needle in somebody for anything, you're going to have the risk of bleeding, infection, nerve injury. So I learned actually that intraneural injection, so if you accidentally inject the nerve itself, is rarely associated with nerve injury, but the risk is there, so we should know about it, as well as muscle weakness, and something called LAST, which is local associated systemic toxicity. So this is something especially important to be aware of if you're doing a large volume block, like a fascia iliaca. And so any patients getting a large volume block should be placed on a monitor to evaluate for any arrhythmias. And you should also have lipid emulsion therapy available in the emergency department when doing a block like this. And another complication is that it can mask compartment syndrome, which brings us to this slide. These are some guidelines that were published by Highland Emergency Medicine's ultrasound website, and they go over the traumatic orthopedic injuries that you should not perform a block in because they're at high risk of compartment syndromes, and then also blocks in which it's okay, and blocks in which you should, or injuries in which you should consider consulting orthopedics before performing the block, as well as some general guidelines. So it's a really great resource. They also have a lot of great information about nerve blocks in general, and I recommend utilizing them. So, okay, so what you need to perform an ultrasound-guided nerve block, an ultrasound. Probe cover, you want it to be as clean as possible to prevent the risk of infection, as well as something to cleanse the skin, like ChloroPrep. Local anesthetic, so you should have some lidocaine on hand to make the wheel, and then whatever anesthetic you're going to use to actually do the block. Spinal needle is not always needed, but in the blocks that we'll be talking about today, you should use a spinal needle for the depth. IV tubing, syringes, three-way stopcock, and believe in yourself. It's the most important part. Okay. And then, so two-person technique I wanted to go over as well. So the idea behind this is that the person who is operating the ultrasound only has one job, which is to get the needle in plane with the ultrasound and identify the structure that needs to be anesthetized. And so the setup that you have here is the spinal needle attached to the IV tubing and a syringe at the end. So you would have an assistant with you, and once you identify that you're in the right plane and your needle's in the right place, you just ask your assistant to flush with saline so that you ensure that you're in the right place, and then they'll just switch out the saline for the anesthetic, and then you can ask them to flush that as well, so you never have to worry about losing your view. Okay, so we will start with a case. You're working in CCT, the notification phone rings, and the calls for an 87-year-old female pet struck complaining of severe leg pain. She arrives to the trauma bay and her vitals are stable and her primary survey is intact, but you notice that her right leg is shortened and externally rotated, and you're worried about a hip fracture. So you get a pelvic x-ray, and sure enough, you see a right-sided hip fracture. So you want to administer analgesia to this patient, but you don't want to overdo it with opioids because she's older and there's risk of respiratory depression and delirium, among other things. So you decide you want to do a nerve block. And you may be thinking of the fascia iliaca block, which is an excellent choice. It's very well-established method and becoming the standard of care for achieving analgesia in patients with hip fracture in the emergency room. I'd also like to talk about another block today, which may be less familiar. It's called the pericapsular nerve group block, or the PENG block. And both are pretty good options for nerve blocking a hip fracture. So we'll just go over the anatomy for the fascia iliaca block. So the fascia iliaca compartment, it's a potential space that lies between the fascia iliaca anteriorly and the iliacus and the psoas muscles posteriorly. So the target of this block is going to be the femoral nerve. The lateral femoral cutaneous nerve gets blocked as well, and very rarely the obturator nerve, because it's so deep inside the pelvic bowl that often the block doesn't just quite reach it. But something important to know about this block is that it's not only sensory, but it's a motor block as well. So you get weakness of the quads and the sartorius and the pectineus muscles as a result. So to get your view, use a linear probe and you place it transversely over the femoral crease, and you need to identify 5 structures for your first view. So if you remember navel from lateral to medial, nerve, artery, vein, and then the hyperechoic stripe on top is the fascia iliaca and the iliacus muscles on the right side. So now, depending on whether you want to do an infrainguinal approach to the block or a suprainguinal approach is how you move your probe. So infrainguinal, you just come out laterally a little bit so that you see the sartorius muscle starting to come into view, and then that's the view you should have. And then if you want to do a suprainguinal block, which is more commonly performed these days, you move the probe cephalad until you start to see the anterior inferior iliac spine come into view, and then you're looking for the sort of bow tie. So if you can imagine, on the left side of the bow tie is the internal oblique muscle, and on the right side is the sartorius. So that's the view you should have for the suprainguinal approach. Okay. I need your help with the oh yeah.
This is a video of the injection itself. So you see your needle approaching from the right side of the screen. The internal oblique is right here. You see this nice anechoic unzipping of the iliacus muscle from the internal oblique. Here's that artery that we talked about. And now this unzipping space formed by your sterile saline gives you this nice anechoic space in which you can redirect your needle, which is crucial when you're confirming needle placement and getting your optimal positioning.
Okay, and this is from core ultrasound, and they used in this block 40 milliliters of dilute anesthesia. In this block, you should use large volume and dilute. So they did 20 mLs of 0.5% bupivacaine with 20 mLs of sterile saline. Bupivacaine is it should be a second choice because it's pretty lipophilic and has a higher risk of the local associated stomach toxicity.
This is a video.
Sorry. Okay. Okay. So this is the PENG block. This is a relatively newer block. It was described first in 2018 by a group of doctors in Toronto. So they argued that nerve blocks that exist for hip pain, including the fascia iliaca block, don't adequately cover the obturator nerve. And why that's important is because they cited recent anatomic studies, including cadaveric studies and MRI, that confirm that the obturator nerve plays a greater role in innervating the anterior hip capsule than we previously knew. So if you look at this picture, it shows you better that the obturator nerve is kind of deep inside the pelvic bowl. And so when you do a fascia iliaca block, usually the femoral and the lateral femoral cutaneous are blocked, but obturator is sort of not consistently blocked, depends on the patient's anatomy. And so the target of this block specifically is going to be the nerves that are inside that box, which are the articular sensory nerves. And so those nerves are branches of the femoral nerve, the lateral femoral cutaneous, as well as the obturator. And so the idea is that if you go more distal, you can target exactly the nerves that are responsible for innervating the hip capsule. And then this block is sensory, it's not motor. So one of the benefits is that you don't get the added motor deficit that you get, or quadriceps weakness that you get when you do a fascia iliaca block. I have another video, I think, or not yet, okay. So the probe that they described this block using first, they used a curvilinear probe because the structure is a little bit deeper. It's also been described successfully used with the linear probe, but usually in thinner patients. And so the orientation of the probe is going to be on the femoral crease, but more in a transverse oblique orientation. And then you move up until you see the anterior inferior iliac spine. And so the target is going to be, you want to try and get your needle into the iliopsoas notch just under the psoas tendon. And this picture demonstrates it nicely. So the angle is pretty steep, unlike the fascia iliaca, and it's steep, which allows you to hopefully avoid those important structures up on the top left, like the nerve, artery, and vein. And so once you get down to the notch, you inject your anesthesia, and then the psoas tendon, along with the iliacus muscle, will lift up off the bone, and the anesthesia should bathe those sensory articular branches that I showed you previously.
This muscle.
Another
Okay.
video.
The needle insertion will be very steep. Here we're using an in-plane approach, and we can see the needle how it approaches the anterior inferior spine. We need to use a little steeper angle, and the needle eventually lands right on the pubic radius, slightly lateral to the tendon of the psoas muscle. Aspiration here is negative, the twitch is absent, and injection pressure is low. And here we can see a layering of the local anesthetic over the ramus pubis, and at the same time, we can see how the iliacus muscle is being lifted by the injection of the local anesthetic. Local anesthetic tracks underneath the psoas muscle as well. And that's a one simple injection to accomplish analgesia after anterior hip replacement surgery. As we remove the needle there, we're going to freeze the image. We're going to freeze the image one more time and use the drawing tools to depict what we actually done. So that's anterior inferior spine. An injection of local anesthetic, as you could see, layers underneath the iliacus muscle in order to feel.
Okay. All right, so we're going to discuss a little bit of the evidence. Fascia iliaca block, as I discussed previously, is like, it's becoming standard of care. Most of the literature is from anesthesia and orthopedic journals, and mostly studied in the operating room. So there's still research emerging in emergency medicine. But these are just a couple of studies of the many that are out there. The first one is a systematic review of 27 RCTs, patients with geriatric patients specifically with hip fractures, and included a total of 2,478 cases. And they stated that fascia iliaca block can help reduce the length of hospital stay, accelerate the functional recovery, as well as reducing opioid requirements. It's a pretty reliable and effective strategy for managing pain in geriatric patients with hip fractures. And the second study here was in the emergency room. It was published in the Journal of Orthopedic Trauma. It's a prospective cohort study done at a level 1 trauma center. And so they had a total of 98 patients, 31 were excluded because of contraindications to the block, but 39 got fascia iliaca block and 26 were managed with only opioids. And they found that the fascia iliaca block group had significantly lower opioid consumption preoperatively, postoperatively, and over the total course of their hospital stay. And as well as reduced opioid consumption, patients with the fascia iliaca block had shorter length of stay overall, on average about 1 day less than patients who were just treated with opioids. All right. The PENG block, like I mentioned earlier, was described in 2019. So that paper that first described the block was a small case series. So the authors decided on this block to target more of the obturator nerve and theoretically achieve better anesthesia, less motor blockade, as well as requiring less anesthetic volume in comparison with the fascia iliaca block. And there was only 5 patients in this initial paper, all of them with hip fractures. Their approach used, similar to the video I showed you, sort of curvilinear probe, transverse oblique orientation, and they used 20 mLs of local anesthetic. So they did 0.25% of bupivacaine with epinephrine. And 30 minutes after they placed the block, they evaluated all patients by asking them to flex at the hip and perform a straight leg raise. And all patients were able to comply and reported significantly improved or reduced pain scores compared with baseline. And they didn't have any quadricep weakness. So that was like the sort of introduction of this block. After that, there was a paper. This is the first, like I guess, study that was done in the emergency room for hip fractures. It was also very small, only 3 patients, and it was published in the journal, American Journal of Emergency Medicine. And it was 3 elderly patients with hip fractures, also 0.5 of, well, they used higher concentration, but also 20 mLs of bupivacaine with epinephrine. And they achieved similar results, 30 minutes onset of analgesia and able to range the hip with minimal to no pain. And so the largest study that I could find on the PENG block was from 2021. It was a randomized comparative trial that included a total of 60 patients and compared the femoral nerve block to the PENG block. And so they found that patients who had the PENG block had better short-term analgesic benefits. So in the recovery room, they endorsed better pain scores, but on post-ep day 1, there was no difference in the pain scores. The other difference was PENG block group had better quadricep strength, but there was no differences detected in the quality of recovery. And so there are still studies in process for the PENG, and there are like some bigger clinical trials comparing the PENG with the fascia iliaca block head-to-head that are expected to result next year. So the evidence is very limited and it's very new block, but based on what we know so far, it seems like it could be pretty promising. And based on the sort of innervation of the anterior hip capsule, as well as the benefit of less weakness in this block, or motor weakness, and potentially improving recovery, there's just a lot more that we have to know about it before we say that one is better than the other. So fascia iliaca is still sort of the standard of care for nerve blocks, at least in hip fractures, because it's so has so much evidence and it's very well established, pretty safe and reliable method. And we just need some more information about PENG before coming to that conclusion. And that's all I have.